Welcome to the Critical Care and Austere Environments. My name is Aebhric OKelly. I am the Executive Dean of the College of Remote and Offshore Medicine. I am a board-certified critical care paramedic and currently doing a doctorate in austere critical care through the Stirling University in Scotland. We'll talk a bit about some of the research I'm doing. First off, as an academic organization, our college is required to provide disclosure statements. I have no financial interest in relation to this presentation or conflict of interest. I don't own any stock in the equipment we're going to talk about, and I'm not selling lots and lots of stuff. So this is the introductory lecture. There's two more lectures. So we're going to talk about what is an austere environments, talk a little bit about what makes an ICU. We'll talk about critical care nursing checklists and some skills that you can start working on now to make you better at critical care. We'll talk about clinical assessment and the body systems approach, a little bit of PFC, but this is not a PFC lecture. That's later on this week. We'll talk about blood gas analysis and some of the things that make an ICU, and we'll talk about the difference of ICU, how it works in the city, and how it works in a rural environment. Okay, what makes an austere environment is generally a situation. So it's happening now in the developing world, and lots of countries I go to in East Asia and Africa have a developing healthcare system. And so their ICUs are not as robust as what we will see here in Europe or in the United States. It could be failing states such as Syria at the moment. Syria has had a pretty good healthcare system in the past, and now it doesn't, just because of the conflict going on at the moment. Natural disasters due to earthquakes or tsunamis or any type of unforeseen event could turn a ICU that is Western level, evidence-based ICU into an austere ICU quite quickly, just because of a natural disaster. We'll talk a little bit about the poor and the economic challenges of running an ICU in difficult locations, and sometimes military operations are going to cause austere environments. It's caused by violence or security issues, public health emergencies, unconventional warfare, and here we are as the medic in the middle trying to be the best we can. And sometimes all we have is what we carry. So we'll talk about that. So critical care in austere environments, it is a situation. It's a mind frame, if you think it's you can have a best location in the world. Let's look at Boston. Boston has 3 very large hospital systems, and it has 3 medical schools, and it's kind of the cutting edge of where you want to be. All it takes is a power outage, and then suddenly Boston is austere critical care. So you have to be prepared for this, and it can happen at a moment's notice. Often beds are a luxury. We're seeing this now with the pandemic, where COVID-19 pandemic, that all ICUs in the world are currently overrun and we're having a bed problem. So you have to improvise. Sometimes, as you see underneath me, there is a bed, quote unquote bed. There is an ICU. There is a critical casualty, has a drip, and they are transporting this casualty as best they can in a hammock. So austere critical care means that you're going to have different standards of nursing care. Some places in the world, they're quite happy to leave someone there for long periods of time and not check on them. And even in the best of times, like now during the pandemic, you're going to have 1 critical care doc, two critical care nurses, and 8 patients that they're dealing with. That's austere. That's difficult to keep up with that. There's different standards of physician and medical officer training around the world. You're going to have someone who's a critical care trained doc, which means that a couple of our faculty are board certified critical care, board certified emergency medicine. So they have spent years and years and years going through these different fellowships to earn the right to call themselves a critical care physician. In some parts of the world, I've worked with a critical care doc who is a pediatrician who does not like critical care, and he's there because he's the only doc and he has no idea what he's doing. And that he is a doctor, he is a pediatrician. So austere critical care means that you're going to be in different environments where there's not the same level of considerable of what people consider top training. Oxygen, you're just not going to get it in a large part of the world, which means that you have to improvise. We'll talk about how to improvise this. Lack of equipment. Now you got to have a wall full of equipment in an ICU. And if you have a mass casualty situation, suddenly you're lacking equipment. You're now in an austere ICU, even though you are in a very large town in the Netherlands and you are one of the best ICUs in the country. Suddenly you're wiped out of all your equipment. You're now austere. We're having that problem with the COVID-19 because of the ventilator problem. So all these top level ICUs are practicing in pretty austere environments. And I'm sure some of you have seen some of the discussions on how to use one vent for 2 or 3 people and why it's causing barotrauma. And so people are struggling because currently in today's pandemic, we're practicing austere ICU everywhere. Lack of equipment, lack of pharmaceuticals. So as a critical casualty, you may have to RSI, and you may have to put them down. You may have to have long-term sedation. Do you have enough drugs to do that? And how do you reorder, or can you reorder in time? Or what drugs do you have available that's going to keep someone sedated? And if you don't, then what are you going to do with this highly critical casualty with barotrauma that needs to be on a vent, but you've run out of muscle blockers or sedation drugs that's going to allow you to maintain this ventilator? There is limited monitoring capacity as well. In lots of parts of the world, you're going to have an ICU that is basically a room with a bed, and that's your ICU. And we'll talk about how to create it, even in a hotel room. Suddenly, this hotel room that you're in with this critical casualty, and boom, it's now an ICU, and you need to be able to have the monitoring capacity, even with very little equipment, to make an ICU. So what makes an ICU? The ability for basic OBS. So we're looking at blood pressure, SpO2, temp, glucose and sugar monitoring, ECGs. These are basic. Everyone should have them. And with the medical equipment we have now, there is zero reason that you as a medic don't have these basic monitoring capacity. So I know I've heard it in our classes in Malta that, I'm just not going to carry an ECG. I'm not going to carry a 12 lead. I'm not going to carry a LifePak 15. You're right. You're not. You're going to carry an ECG. There are vast amounts of ECGs that are this small. We have 4 of them now in our training rooms in Malta of different capacities and different companies. I'm not going to say what type that is, but there's a lot of them out there that can give you 3 lead and 4 lead ECGs. So can you have this in your pocket? Absolutely. Is there any place on the planet that you won't have the ability to get these basic observations? No. If you want to be a critical care practitioner with the ability to work in difficult, austere, resource-limited environments, then you need to get the equipment available to you and always carry with it. This is an SpO2 and it's not a 12 lead, but it's a 2 lead ECG that I can move around the body to get my 12 lead. This is always in my computer bag. So no matter where I am in the world, on a flight or anywhere, I'm going to have that availability. So have your basic obs, have your basic observation abilities. have hemodynamic monitoring. And we'll talk about that. The third lecture here is about non-invasive hemodynamic monitoring and how you as a medic in an austere environment without a Swan's catheter, without some of these really invasive tools available for an ICU that an ICU should have, that we don't have that ability. Or even if I had one on hand, I wouldn't put a central line in a very remote environment. It's just too dangerous and risky for infection. So we need you to have the ability of hemodynamic monitoring with just the basic equipment you have. So you need your basic monitoring ability, you need hemodynamic monitoring with that kit, and you need to get the availability to give blood products, whole fresh whole blood preferably. You need to be able to give hemodynamic drugs, so vasopressors, and you need to have the ability to RSI and know how to ventilate. If you have those three things, you have a very good ICU. So minimum, better, best. We are using what the Prolonged Field Care Working Group has come up with, the standard of minimum, better, and best. So at the very minimum, you as an austere critical care practitioner, you need to have your bed, and you can put a bed anywhere, right? You saw the hammock these guys were carrying with a log between them. That's a bed. You need your blood pressure, you need your SpO2, you need your 3-lead, you need to be able to catch urine. So you don't need a Foley. Foley is best option, but you need to check urine output, and you can do it just by catching urine. Make sure that you measure all the urine that's coming out of him or her. You can do it just by catching. So that's the minimum. The better option would be all the above, all the stuff for the minimum, but a 12-lead ECG, or have the knowledge on how to use one of these to get all 12 leads, and a Foley, which is, you should probably have that so you don't have to worry about catching the urine all the time, and the ability to do hemodynamic monitoring. Now, I didn't say all these invasive hemodynamic equipment. I said the ability to do hemodynamic monitoring with just the basic stuff. So that's better. That's better than the bottom line. But the best option is all the above, the ability and the experience of treating these hemodynamic problems, your experience with ventilators and oxygen, and experience with ultrasound. Therefore, our college has a challenge to you. You have the ability to practice best evidence critical care under austere environments. And we're going to talk about how you can, what skills you need and what knowledge you need to work on that. So to be the best, you need kit, but you need this as well. So let's talk about both of those. The basic OBS kit everyone should have. Your blood pressure, your basic EMTs are going to have this: a blood pressure, SpO2, thermometer, probably a 3-lead ECG, and urine catch. Your ECG monitors come in various sizes, and they're like this one you see right below me. That's a 4-lead ECG. It's actually pretty good. We have one in the classroom in Malta, and it's pretty clear and concise, and it's that big. And it's something you can carry in your ruck. I wouldn't carry that with me. This I can carry in my shirt pocket or computer bag. That big one below me, I can carry in a truck or my backpack. How to be the best. We're going to talk about being good at the basics, just the basic stuff that you should know really, really well. We're going to talk about the critical care nursing skills list on some of the skills that you can practice to make yourself a better critical care practitioner. We'll talk a bit about PFC. Now, this is not a PFC lesson. That's coming later in the week, but they kind of go hand in hand. And we'll talk about where PFC falls into place in the patient assessment compared to the austere critical care. You need the ability to monitor hemodynamic variables. Talk a bit about blood gas and know your acid-base balances. If you have that ability, or if you have that blood gas kit, we'll talk about that. Talk about innovation and improvising medicine. But the bottom line and how to be the best is you can read a book, you can take these webinars, you can get lots and lots of this knowledge, and that's really going to put you on the path of becoming a good critical care practitioner. But it's this knowledge that is going to make a difference. So you can have all the knowledge of books, you need the knowledge of the hand as well, and that can only come with hands-on experience. So I would encourage you to get the basics of the didactic learning, the book learning, and then come to Kilimanjaro, or find, you don't have to use our college. You can do anything. There's lots of volunteer organizations out there. Medicine Sans Frontiers would probably pay you to go and do some of the austere locations. But we send people down to Kilimanjaro in northern Tanzania, where they can have, we have agreements with 22 hospitals where they get experience in the medical wards and emergency wards and ICU wards with docs who spend time in Europe and in the United States in critical care units. So they're very good. They just don't have a lot of equipment. And that's what I need I'm doing my doctorate down there. That's what I need to have docs and nurses have this knowledge, know what the standard is, evidence-based practice is for critical care, even though they don't have the equipment available. So the picture below me is from Kilimanjaro Christian Medical Center in the emergency room. All right, what you can do is you can be good at the basics. As a critical care paramedic, we have all these really cool high-speed skills. We can RSI, we can give drugs to people to make them kind of die, and we have drugs and make them come back to life. We have lots of skills, put tubes down, people are completely fine. And we can do chest drains. We can do all these really cool skills, but that is not what makes me a good critical care paramedic. I have to be good at the basics. Now, the basics means that putting something fluffy under the casualty, and in remote environments, austere environments, you're going to have the guy for 24 hours. If you want to be good at this austere medicine, then you need to think about the basics. So get them on a blanket, get them on a cushion, rotate them, make sure that they're not getting pressure sores. It takes 30 minutes of someone laying in one spot before they get ischemic injury. This is published material. So be good at the basics, at keeping your casualty comfortable. Listen to what the casualty is saying. They're whinging. Sure, they're in pain, but listen to them. They will tell you what's wrong with them. They'll tell you get a lot of information from the history. We'll talk about that. Privacy. So as a city-based paramedic, we're used to just stripping everything off of everybody and doing everything we can, and then maybe wrapping them up before we throw them on the ambulance and throw them into the emergency room. And then we walk away and pat ourselves on the back. That's not good. So have some privacy, have this patient, especially if you're in a culture where that is a taboo, nudity or nakedness, or been on an ambulance responding to a mosque, and we are not allowed to go into the mosque because I'm not that religion, I'm not that. So we had to treat this casualty and in a very respectful manner, and that is paramount for you as a healthcare practitioner, to give the casualty privacy and respect the background they have, and in the meantime, you need to practice your medicine. You need to make them better. Other basics, pain management. We're really bad at that, and there's some good studies out there in PubMed saying that PTSD is doubled or tripled for anyone who doesn't get early access to pain management. And even patient outcomes past the PTSD problem is decreased if you don't manage the pain. We don't take away the pain. We call that RSI. So yeah, we can take the pain away, but that means they're unresponsive. They're GCS of 3, and now I breathe for them. But we make the pain manageable. So be a good medic and make the pain manageable. It's better for the casualty. They're not whinging as much, because an environment like austere environments we work in, we're with the casualty for long periods of time. So I don't want to hear them whinge all the time. So take the pain down to a level that they can manage. Drink. Everyone drinks. And in city-based, I'm working on an ambulance in a city as a paramedic. No one drinks. Oh my God. I don't care what's wrong with you. You don't drink. You could just have a stubbed toe. Oh, don't drink. Oh, you're going to die a horrible death if you drink. That's wrong. And it's actually dangerous. In our environment, because we have casualties for long periods of time, they have two options. You can hydrate or you can die. So everyone drinks. If they have a belly injury, then yeah, you can query that. But everyone swallows about 1.5 liters of saliva in a 24-hour period. With a critical casualty, we're not telling people to spit out their saliva. We're allowing them to swallow saliva. They can drink water, clear water, and hydrate that way. You can also hydrate other ways. We'll talk about the hydration ladder, but this is also about the psychological well-being of your casualty. If they're in pain and they're thirsty and they're scared and they've been lying on your scoop stretcher for 45 minutes and their butt hurts and you haven't taken care of all these basics, you're not doing well as a critical care practitioner. And the last thing is document. Document as you go. I'm a lazy medic, as like everyone else, and I don't like documenting, but I don't like documenting the catch-up game. So forgetting to document for 45 minutes, and then you're trying to remember, what did I do with this person 45 minutes ago? So document as you go. So be great at the basics. Here's a skills list. This is found in our field guide. Our 2nd edition field guide is here in the warehouse. We're about ready to ship. This is page 294 of the field guide. And here's just a list of critical care skills that you as a provider should know. And you can come back after this webinar and pause this video and take a look at the list, or you can buy our field guide and take a look at it. But these are what you need to be good at as a critical care provider. Because we are dealing with a critical casualty, the CABC or ABC or whatever assessment system you use as a paramedic or a nurse is good to stabilize this person. It's not enough in a critical environment. There's things we're missing. And so you need to use the chart or the soap notes. There's a lot of different note taking ways to do this out there, but basically you need to go through, after you've stabilized this person with CABC and stopped all the major bleeds and everything, then you roll over to a clinic-based assessment. And at the college, we use the chart system and the clinic-based assessment. We'll talk about this a bit more. Prolonged field care is something that transitions you from the CABC into the chart-based assessment, and it's based off of Hitman, and we will talk about that in another webinar. All right, let's talk about hemodynamic monitoring, and this is what is our bread and butter as critical care practitioners. So we need our vital signs, we need our output, so urine output, lactate levels, some laboratory. So if you can do CBC or chem panel, ultrasound, these are going to give you some hemodynamic parameters that is still technically non-invasive. And there's some calculated measurements as well that we can talk about. So blood gas analysis in a remote environment, that is definitely an option for us. There's no reason why you shouldn't have this capacity as a critical care practitioner. There's two options out there. On the right, you see the iStat from Abbott, and I've used that for, 15, 20 years now. And on the left is the Epoch from Canada, I believe. They've come up with a new one. The blood gas analysis machines are going to look at a bunch of your variables from your chemistry, your blood, and your blood count. And using this information can give you a lot of insight on what your critical casualty is doing. So if you're working for Médecins Sans Frontières, or if you're working for an expedition that has the capacity to purchase these or rent these, this is going to be very helpful. The iStat on the right is a bit problematic because the cartridges that you see, you can see the hand pushing the cartridge in on the bottom, those require refrigeration. So if you're on an oil rig, brilliant. So you have a refrigerator, or the cook does anyway. If you're on a seismic vessel, or if you're on a cruise ship, there's no reason why you shouldn't have this, because you have refrigeration capabilities. The one on the left is what we have in our classroom, and I don't own stock in this at all, but those cards do not need any type of refrigeration. And the other thing with the Epoch on the left is you don't have to, every 6 months, you don't have to update the software, which shuts you down completely. On the right, the iStats are horrible, that every 6 months, if you don't plug it into a computer and get a download from Abbott, you have a brick. You have absolutely a brick in your hand that doesn't do anything at all except hold a door open. And that's not a problem if you're in an ICU somewhere in Belgium or South Africa or Taiwan. But for those of us working in austere and resource-poor environments, we don't have the capacity to update every 6 months. So the Epoch is probably a better option for us. Improvisation. So this is a book that I highly suggest you guys to get. You can just go to Amazon or go to whatever bookseller and order it. It's called Improvised Medicine. There's 2 editions. Either one, yeah, it's fine. But this is a wilderness medicine doc, and he has a 300, 400 page book on things that he's used in austere environments to create medical equipment, how to make bandages using bed sheets, and how to sterilize them. And it's definitely worthwhile to learn some of these skills if you're going to be in an austere critical care environment. On the left are some of the things that WMS, the Wilderness Medical Society, have discussed as far as improvisation. You see an ankle brace with duct tape and a leg splint and there's some snowblind glasses with duct tape. Funnily, duct tape is on all 4 of those. So yes, duct tape should be in your packing kit. Maybe not on your person, but I would definitely carry it in my truck kit or ambulance if I had that. So part of austere critical care means the ability to improvise. And we're not saying dropping the standards, dropping the level of care. We're saying provide evidence-based medicine level of care, but you may have to think outside the box. You may have to create something with duct tape that still works. So IV warming bags. You can buy the Angel system, which is $15,000, I think. We don't have one in the college, of course, because we're nonprofit and I can't justify paying that. But what we do in the college is we get some duct tape and some hand warmers, some chemical hand warmers. We pop open the hand warmer and open up and shake it up the bag, and then wrap the IV around it, and then duct tape that together. And then now you have warm fluids going into the casualty. In fact, you have to be careful because it might be too warm. So improvisation means that you have to monitor a little bit more. So if you want to be a good medic, even if you're not going to be in an ICU that's in austere environments, just your day-to-day medical practice, why not have this improvised medicine book available? It's and there's a couple others out there like that. All right, let's talk about the difference between a city-based response and a response in an austere environment. So we have a critical casualty, and the point of incident, or where this person started to get sick, is a house. So what happens is they call 999 or 112, and we come in in an ambulance. Many years of doing this and showing up at the house. Oh, there's a critical casualty. Put it in the back of my ambulance and drive very fast and drop them off in the emergency room. And then we're done, right? And the emergency doctors, they see this critical casualty. And they're like, quick, keep going. And they do a little bit and then they quickly send them off to ICU. And so on the bottom right is where that critical casualty really wants to be. You want him or her in that environment. So surrounded by technology, surrounded by medical professionals that do this all the time, and they have all the equipment available to deal with anything that's coming up. And the pandemic at the moment with COVID-19, this is happening a lot. Somebody's getting super sick. They're losing consciousness as they're trying to breathe. Somebody calls 112. They get them in the ambulance, get them in the emergency room. Maybe they don't even get into the emergency. Maybe the emergency room just bypasses and says, COVID, go into ICU. And that's where you want these casualties to be. And that works really well in a best case scenario in a city-based response unit. But we don't work in a city, do we? Austere environments is a bit different. So there's our point of incidence. It's a jungle. We're in the middle of Ghana, and not even Accra. We're way north Ghana, which is, come an 8-hour drive, or if you're lucky, an hour flight to Accra, where you want that ICU treatment. But it's your job as an austere practitioner to start at the point of incident and start treating this casualty. And you might get him into a transport, which is not what you would expect. It's not an ambulance. It's an SUV. If you're lucky, you get an SUV that has enough space in the back to work on this casualty. And then you're going to evac them, not to an emergency room. You're going to evac them to your clinic. So maybe you have a clinic set up in a shipping container box somewhere in northern Mali, or you're a tent as you are going up Mount Kilimanjaro. That's a 9-day trek, and you're not going to carry a Connex box all the way up. You're going to have a tent. So that is where you bring back this casualty to stabilize into a tent. And that is your ICU until you can get this guy into a local emergency department, if you have it available. And then from there, they can arrange an evac by plane back to home of record. So if you're from Japan climbing Mount Kilimanjaro, you as an austere practitioner can stabilize this guy as best as you can, get him into the local emergency department who will stabilize them, and then call for a plane. And your insurance company will send a plane and take you back to Narita so you can get an ICU in Japan. So that takes a lot longer than what we're used to. So this is the city-based response. And from point of incidence where me as a paramedic arrives in through the door of the house to the time where they get in the ICU, it could be as little as 40, 45 minutes. So not here. This, where we could talk 8 hours if you're lucky to get them from point of incident to somewhere on a plane to get them back to their home of record. So, it doesn't happen very often. You're talking sometimes days. So it's your job as an austere practitioner to work in every one of these locations to keep your casualty stable, to resus if you can, and get this casualty on the plane back to home of record. This is our specialty. And my challenge to you is to learn the skills and get the experience to practice in these 3 locations at evidence-based best practice medicine, using your critical care skills and experience to keep this casualty alive. So this is what we want in the bottom right. We want the best for our casualty. And the guys in the bottom right, they have their own assessment system, and they generally do an ABC assessment, and then they're going to skip right over to the SOAP note or the clinic-based assessment note. So they don't have to worry about catastrophic hemorrhage. They don't have to worry about environment. They don't have to worry about vital signs. It's all right there. So as in an ICU unit, they have a different way of assessment. For us, we have to be better than that, because we have to find a lot of this information ourselves. Where the docs, they walk into the room on the bottom right, and the observation, all the vital signs are there, the trending is there at a glance, and their hemodynamic parameters are there at a glance, and it's easy to find that information. For us, the austere practitioners, we don't have that. We have to find that ourselves. My challenge to you is to use the knowledge that you have as a normal paramedic or nurse or doc, using your assessment found in emergency room or pre-hospital, and use it to your advantage in austere. So this is what the ICU guys use. We need something else. This is what we're going to use. And what we've done at the college is we've taken our normal CAB trauma assessment and used it as a starting point for the critical casualty. If you only use your CABC approach, you're going to miss a profound amount of knowledge for your critical casualty. For your trauma casualty, we all love trauma. It's easy, isn't it? You do your CABC, you stabilize, and a little beam of light comes down, hits you on your head, and you did a good job, and you go get your lollipop, and you go back to your ambulance, and excellent day, right? It's simple. Not so for the critical casualty, not so for someone who is big sick. So we're going to use our CABC assessment to quickly go through the trauma assessment to make sure that we didn't miss anything. So even if you see somebody coming, you're in a clinic in northern Tanzania, and it's just somebody walks up to you who doesn't look well, they probably don't have trauma, and maybe they have nausea, vomiting, diarrhea, and they're very diaphoretic in temperature. But we still, because we're pre-hospital, we're going to start a catastrophic hemorrhage and just do a quick look. Catastrophic hemorrhage, airway problem, no, okay, breathing problem, no, they seem to be all right. C, circulation, okay, a little bit of red flags there. D, disability, we're looking for any type of broken bones or neural, no, okay, that's fine. Go down an environment, are we too hot, too cold? No, we're fine. And finally go through our whole CABC assessment quickly to make sure we didn't miss anything. And then we can roll over to the right side, which is our chart assessment or our clinic-based assessment that we'll talk about. So as a critical care practitioner in a hospital, you just do ABC, stop, and then roll over and start doing your review of systems and things like that. We can't do that pre-hospitally. And this is one thing that an ICU doc has a challenge when they go out on expedition and they expect a wall full of equipment, and they put out their hand and they expect a nurse to suddenly give them hemostats, and no, it's just them. They need to pick up their game a bit and see the pre-hospital assessment and the value of that as well. So you need two things. You need your trauma assessment, your CABC, and you need your clinic-based assessment. Both of those things together are the critical casualty assessment. And we have these on page 6 and page 24 of our field guide. So first thing we want to do at the point of incident, where this patient is, stabilize. We can do a quick scene assessment and CABC to make sure that they are not bleeding out. They don't have an airway problem. We have to do a surgical airway or a chest drain or something, and just stabilize the casualty. Throw them in the back of the transport. Get them into your clinic. Now, in your clinic, you have at least your backpack. And generally, when you're working in remote, you might have 2 or 3 big bags of medical equipment as you arrive, and you hang them on the wall and they stay there. But then you have your trauma bag that goes with you to treat the casualty, but you need them back into your clinic on the left, their bottom left, because you have the rest of your kit there. You might have a full 15 life pack 15, and you might have a bunch of extra equipment like a EPOC, blood gas analyzers. You need to bring this casualty back to your clinic. And this is now your ICU. This tent is your ICU. And ICU can be anything, right? We learned from the very beginning All you need is a bed. You need you with ICU training and ICU experience and the ability to do basic obs. And that's it. And this is your ICU. Once you're here, you have done your CABCs all the way down to disability environment, and you got your full set of vital signs and you documented everything down. And now you can roll over to the clinic-based assessment. And we'll talk about this a bit more. We use chart. Some people use SOAP notes, and we just found chart being a little easier to remember. But it's basically getting medical history off your casualty, review of systems to check any of this. We do a full systems check just to see if there's anything that we missed. We'll talk about treatment and telemedicine. It's always good to call someone on sat phone or a mobile phone handy that it's a specialist that you can confer to. And, you know, docs do this as well. Emergency doc is going to be calling an infectious disease doc for a referral. So, you know, if docs have no problem calling a referral in, like, come on, we as austere practitioners should have that same level of care for our casualty. So I'm going to get on the sat phone and I'm going to do telemedicine if I can for any questions that I have. All right. So as far as an introductory lecture to what is austere environments, we talked about what makes an ICU, so that this casualty below me is in a tent, in a bed, a tent type bed, and he's got a drip in, and that's your ICU. So be good at the basics. Have all the equipment you need to get the basic obs for this casualty. And with those basic obs, we're going to be able to calculate hemodynamic parameters. We'll talk about that in the upcoming lecture. But with the ICU that you see here in the bottom right, it's enough. All right, does it have oxygen? No oxygen. Vent? Nope, no vent. So it's not the best ICU, is it? But that's your ICU. And in a best case scenario, you would have what we saw a few slides together, a wall full of equipment, 2 or 3 or 4 docs who are just standing there doing everything they can for this casualty. That's what we want. In an austere environment, that's not what we get. My challenge to you is be good at the basics. Be good at the critical care skills that are patient care, of making sure that the casualty is not in pain or limited pain, casualty is drinking, the casualty's head is lifted so it can engage with the environment around them. Know how to do your body systems clinical assessment. We'll talk about that in the next lecture. No prolonged field care, because you're going to have this casualty for a long period of time. The austere, in the whole concept of austere critical care, we assume that you already know prolonged field care and you have experience in that and training in that to get into the point where you can roll over from prolonged field care and add on some of this austere critical care. We talked a bit about blood gas analysis and improvisation, and get some books and practice on your own on some of these improvisation skills. We talked about the differences between ICU response in the city, which is perfect. It's lovely if you can get that, and ICU response in remote areas, and why you as a expert austere practitioner can provide as best as you can a city-based ICU, even in a remote environment.